Professor Siebenrock, thanks for the opportunity to talk about our 10-year results after surgical hip dislocation. When Mark and I started this 12, 13 years ago, we made a conscious decision not to stand up and present any results until we got decent long-term follow-up, because we really believed we could only decide what to do in the future if we understand what we've done in the past. So this is very much a historical talk about what we were doing some time ago. So these are our 10 to 12-year results. They represent the first 2 years of our experience of this technique in a small district general hospital in the far southwest of England. It's not a teaching centre. Mark and I are fairly experienced hip surgeons with paediatric and arthroplasty background and some pelvic surgery and acetabular fractures. We both ran young adult hip clinics when we were frustrated at the lack of our ability to deal with people in that window between the end of my paediatric practice and the point at which most people were comfortable to do joint replacements. Interestingly, our hospital and the people who purchased care banned us from starting a hip arthroscopy service because they thought it would cost too much money and they wouldn't allow us to do it. So we had a bit of a hallelujah moment when we read this paper from Professor Gantz and his team here in Bern, because this gave us the opportunity to bypass that and you're not allowed to do hip arthroscopy procedure. It's a fantastic paper. It told us how to do this magnificent operation. It told us why to do it. But it didn't tell us who to do it to, and it didn't really tell us what to do with those patients afterwards. So very much we were on our own learning what to do. We did this for about 5 years before the managers noticed that we were doing this young adult hip surgery, because we just called them femoral osteotomies or hip dislocations. We didn't mention arthroscopy because we weren't doing it, but we got away with it. And by that stage, we got to the point we'd done so many that they couldn't stop us. Maybe it's a lesson on how to manage health service care in England. So these are our first results. We've got 47 hips in 45 patients. At the beginning, we had a wide variety of diagnoses, but 90% of them were FAI, but there were a few oddities at the end that we thought we'd try, and it may have had an effect on the results. Fortunately, nobody's died, and Cornwall people tend not to move very far. They don't like to cross the bridge into the next county, into Devon, so we've got no loss to follow up, and we've got complete radiographic follow-up on all of our patients. For the purpose of this talk, our definition of failure was progression to a total joint replacement. This is our Kaplan-Meier survival curve for all of our patients for all reasons that we did the surgery, and we've got overall a 70% survival at 10 years. I didn't really know whether this was good or bad, but it was reassuring yesterday to see Simon presenting the results from Bern, which showed the Kaplan-Meier survival for with labral reconstruction at the top and without labral reconstruction at the bottom. So we're pretty much slap bang in the middle between the two. We looked at factors that we analyse as possible predictions of failure, and including age, gender, how good we were at surgical correction, the tonus grade and the presence of osteoarthritis, and their impingement pattern. And I'd just like to go through some of these results now. Age didn't really seem to affect whether or not you ended up with a hip replacement or not. There was no significant difference in those groups that proceeded to a joint replacement compared to the ones that were successful at the end of the 10-year period. We've got more success slightly in the females than in the males. And the thing that we found that was most prevalent with the pre-existing risk of arthritis was a risk to failure. Now, looking back now, it's fairly bleeding obvious that that was going to be the case. So for tonus grade 0 to tonus 1, we've got very good survival rates at 10 years, but as soon as there's any presence of arthritis, things fall off a cliff. Now, one of the things I'd just like to explain is at this stage, Mark and I were fairly prominent hip resurfacing surgeons. We used the Gantz approach for all of our hip resurfacing at that stage. So we were taking on a lot of people where we just do the dislocation to see whether or not we could get away with a dislocation, a debridement, or whether or not we proceed straight on to a hip replacement. And clearly, looking back in time, we should have just been doing hip resurfacings or replacing all of these groups where there's any doubt. So now if we even think about a resurfacing, we just go ahead and do it and we don't offer them a debridement. Looking at the impingement pattern, we found that all of our pincers have survived out to 10 years. The cams, or the combined cam and pincer deformities, have done the worst on the whole. So it appears to be the cam and the propensity for chondral damage that is having an effect on the results. At that stage, I wasn't doing PAO surgery at all, so we were trying to use the debridements to manage some of these problems, and I overcorrected a few with a bit of enthusiasm when I was trying to do labral repairs. What we did find, if your center edge angle remained within a reasonably normal range, we got good results. If we made them dysplastic or treated dysplastics with surgical hip dislocation, our results are lousy. And if we undercorrected the pincer deformity, the results were also not quite so good. It follows a standard surgical principle. If you do the operation well, you're probably going to get good results, and if you do it badly, you'll not get good results. This is echoed in our CAM corrections. Right at the beginning, we were not using templates. We were eyeballing where the deformity was and resecting it. We got better, and we used the templates later on, so we completely corrected the CAM. We've got much better results, and if we didn't do the job properly, we got lousy results. What was interesting, in a small subgroup of men under the age of 40 without without degenerative change at all, we've still got 100% survival. So it emphasizes that view that even with a CAM deformity, if you've not got arthritis, it's a very good operation. These are results for survival with and without labral repair. Again, if you repair the labrum, the evidence suggests that we're going to get better outcomes at 10 years. And if you don't repair it, the outcomes are worse. And these are the results from Simon's talk yesterday from Bern, again showing very similar outcomes at 10 years. So maybe we're not doing it so badly after all. There's a noticeable difference in ours. We've got a drop-off right at the beginning, which I think is probably that resurfacing effect that we talked about earlier. 15% of our patients had an arthroscopy or further open surgery, particularly in the first couple of years as we were going through the learning phase. We took a couple back to theatre reasonably shortly after their surgery to redo it and make sure we'd corrected the deformities. But after the first 2 or 3 years, the vast majority of people have not required any further surgery. So the question I think that's important for patients is, did they think it was worthwhile? Our mean non-arthritic hip scores at the end of the 10-year period were 80 with a median of 88, the range of 30 to 100. Our Oxford hip scores had a mean of 39, median of 42 with a range of 24 to 48. It's important to ask the patients really whether or not they're happy with the surgery that they've had, because I think that is a really important, it's what we're all trying to do. Are we trying to make people's quality of life better? So if we looked at their initial happiness with surgery following this right at the beginning, the vast majority were at the upper end of satisfied or very satisfied with their surgical outcome. We just use a simple 1 to 10 scale visual analog score. Then we asked them how happy they were with their surgery after 10 years. And again, we've got 1 or 2 ones that dropped off at the beginning, that have gone on to joint replacements, who were not happy and wish they hadn't bothered. But the vast majority are tending to still being satisfied with their choice to have surgery at the end of the 10-year period. And again, the vast majority, there's a big peak at the end that all thought their surgery was worthwhile, with obviously the failures regretting it and wishing they hadn't had it done. But 80-90% of people deemed their surgery was worthwhile at 10 years. What is interesting is going from the first 2 years when we were very much learning on our own with little advice. There were more information about people we should be operating on. We came to Bern to make sure we were doing the surgical technique right. What was interesting of the first few patients we saw Martin operate on, Mark and I looked at the hips and thought, bloody hell, they look almost normal. And that was when the move to staying away from that, should we resurface or not, came into play. We've got dramatically better after the first 2 years through the learning curve on our own. I would hope that now with so many people doing open hip debridement and decent fellowships that most people shouldn't need to go through that first 2-year learning curve. So what changed? Our patient selection got better in the 3rd year. We started to use femoral head templates at the beginning to guide our femoral head resections. We got better with the patient rehab and had far fewer problems with the trochanteric osteotomies failing to unite. And we also introduced PAO for dysplasia and became a lot more aware of the dangers of using surgical hip dislocation for people with any potential for dysplasia. So in conclusion, the factors affecting long-term outcome in our series are predominantly surgical judgment and experience and skill. We got better at it and there is a learning curve. Pick patients with minimal or no osteoarthritis and you're likely to get a good result. For God's sake, don't make them dysplastic because you'll end up with a lousy result, and you've got to fully correct bone defects properly. Thank you.